Hi everyone, thanks for joining us. Welcome to the latest webinar from Arthritis Action. This webinar is Arthritis and Podiatry. My name is Owen Buckley. I'm the Communications Officer here at Arthritis Action. Today we're joined by Dr. Richard Wilkins, who is a clinical academic podiatrist at Leeds Teaching Hospital NHS Trust and also the Foot and Ankle Studies in Rheumatology Group at the University of Leeds. Richard's going to be giving us his professional perspective on all things podiatry for people living with arthritis. Thanks for joining us today, Richard. How are you?
Good, thank you, and looking forward to going through my presentation, and hopefully we'll cover sort of more of the general issues around foot and ankle disease, especially in relationship to the various arthritis. So yeah, thank you very much for inviting me over today.
Brilliant. We're also joined today by Arthritis Action's Therapies Manager and Exercise Lead, David Vo. He's also a registered osteopath in clinic, so he's going to be chatting to Richard a bit during the webinar. How are you, David?
Good morning. Yes, very well, thank you, Owen. And thank you, Richard, again, for taking time out of your busy day to come and talk to us. I know you're up at St James's Hospital in Leeds and literally in between running clinics, so we're very grateful for your time. I'm really looking forward to this one. There's been a great deal of interest from the members, more than a lot of other subjects that we've actually hosted, so we're really looking forward to hopefully answering a lot of the questions that have come in. And I guess without further ado, Owen, let's hand over to Richard so we can enjoy his presentation.
Yeah, just before, I just want to say thank you also to the attendees, as David says, who submitted questions beforehand. We'll be responding to them later. If any of you are watching live and you have a question that you'd like us to answer during the webinar, you can click on the Q&A button that you'll see at the bottom of your screen and then type in your question. And then a little later on in the webinar, we'll get to the Q&A section and we'll try to answer them. If we don't have time to answer any of them, then we'll be sure to email you after the webinar. Just a reminder about that, unfortunately, we can't answer any personal questions regarding your specific medical circumstances, but we can answer more general questions around podiatry and arthritis. Also, yes, a reminder that I said a bit earlier that your cameras are off for this webinar, so please do feel free to stand up or stretch at any point as you need. Yeah, so without further ado, then I will pass over to Dr. Richard for his presentation.
Thank you. So I'll just bear with me 2 seconds while I do the admin part of doing the presentation, and we should be able to get started. Okay, so can we see that, guys? Are we okay with that? Yeah. So I'll just start by just introducing, like, I'm a clinical academic podiatrist. I work for, as if you've been alluded to, work for the University of Leeds as a research fellow in a foot and ankle studies group, and we specifically look at patients who have various different types of arthritis of the foot and the ankle. And clinically, I'm an extended scope practitioner or advanced practitioner in musculoskeletal disease, and I work across a plethora of different conditions, but specifically I specialise in blood-induced joint damage, which we won't be covering today, but it does bow nicely across a varying different spectrums of arthritis. And I hope by the end of today, you're going to get an appreciation for how these different arthritis affect the foot and ankle. We're not going to go too deep into the detail, because I could give you a presentation on one specific part of one specific condition, which would probably cover a couple of hours. So it's going to be very brief, run over the conditions and just how podiatry fit within the remit of provision of lower limb management. So podiatry, often previously referred to as chiropodists. Some people that still call themselves chiropodists, but podiatry is what generally people who qualify now call themselves. It's a role that is to deliver management of foot and ankle pathology or lower limb pathology, and most podiatrists, if not all, are trained to degree level, with the majority of those studying at higher levels as well, so master's degrees. And there's a cohort of us now who have PhDs as well. I'm doing various different types of research across different diseases. It's a healthcare professions council registered profession, so we have to abide to a certain standard of proficiency, of which we're assessed every 2 years to see we're still meeting a certain standard of practice. and we work across a very broad range of conditions which most people probably don't know about. So the pictures I put up there are fairly sort of traditionally thought of as podiatry, which is nail cutting, generalized foot care. We do minor surgical procedures in things like ingrown toenails, but we also deal with patients who've got arthritis and disease of the foot and ankle, which involve foot deformity and various other conditions. We work across rheumatology, so that's a spectrum of inflammatory arthritis and connective tissue diseases, providing foot care. There are a cohort of podiatrists who specialise in surgery and undertake surgical procedures of the forefoot, midfoot and hindfoot. I've already alluded to the research element of that, and there's quite a lot of very interesting research going on in foot and ankle disease. There's a cohort who work in sports medicine, so that's more of the acute type injury or coaching or high performance athletes. And we're now, there's quite a substantial number of people within the profession now who have independent prescribing status. So we can prescribe certain drugs related to our clinical practice. An example in my practice is I can prescribe antibiotics for things like foot infections, but we also access to things like diagnostic imaging. So again, things like diagnostic musculoskeletal ultrasound. And then we also work in footwear as well. So we can modify footwear. We do work in vascular disease. So looking after patients who have quite substantial reductions in the blood supply to their lower limbs and loss of things like sensation in their foot and ankle. A lot of these cross over in various diseases. The foot and ankle is a very complex structure. The foot itself is made up of 26 individual bones. If we count in the ankle, that's another 2. And there's, if we think about how many bones there are, there's also quite a lot of joints as well, and ligaments that hold those joints together, and quite a number of muscles and tendons and ligaments that come down and insert into the foot itself. It's a complex biomechanical structure. And what I mean by that is biomechanics is a phrase that we use quite often in podiatry, but essentially it's about how do we walk and how does your foot interact with the floor when you hit it. So in the simplest terms, it's there for us to stand on, but also when we're walking, it's there for us to hit the ground with. We have to be able to support our weight on generally one foot, and then so the foot needs to be able to adapt to the terrain we're standing on, but also it needs to be a rigid structure for us to push off so we can propulse ourselves forward when we're walking. And as I alluded to before, the foot's the furthest thing away from our heart. It can be the first thing to be affected by circulation disorders. The very common disease diabetes is becoming more and more prevalent in the UK, and that has a significant effect on our foot and ankle. And that can be down to things like increased risk of foot infection, loss of sensation in our foot, and vascular changes, which ultimately lead to us at risk of long-term chronic disease of the foot. And we also go back to joint disease, joint disease associated with damage to the joints. Osteoarthritis is probably the most common foot and ankle problem that we see. And we no longer think of osteoarthritis as a common, as a wear and tear condition. It simply isn't that anymore. We know that it's driven by things like trauma or injury to the joint, and that joint injury leads to inflammation and immune response within that joint, which leads to changes to the joint in structure and function, and also changes to the joint itself. So it's narrowing of the joint, and that joint loses its ability to do its original function. One of the most common places we see osteoarthritis is the foot, is the big toe joint. And it leads to things like, I don't know if you can see the arrow moving there across the screen. Can you see that, Eon? Is that, yeah? So this is like narrowing of the joint space. So essentially we lose the cartilage in between the joints. We also get these changes around the edges of the big toe joint. So the joint starts to widen and broaden and almost wrap around the joint either side. So it's the body's ways of trying to stabilize the joint. But also within that, we get this is an ultrasound image of somebody's big toe joint. So it's a scan from the top of the foot and almost taking a cross section through. So it's like somebody's chopped through the big toe and we're looking at it this way. And what we see there is big osteophyte formations around the joint. So these are big lumps of bone, which is doing what we described before, which is that sort of the joint trying to ossify itself, but also this inflammatory process in the big toe joint. So This is inflammation within the joint itself. This is power Dopplers, and this is a measure of inflammation. So there's an inflammatory process going on within that joint, which is leading to the joint chains, pain, stiffness. We also see osteoarthritis in the midfoot very commonly, and it's the same thing. We have, where two joints meet, you end up with bone bruising either side of the joint, and this inflammatory process and bony changes as the joint's trying to stabilize itself. Less common is ankle osteoarthritis. So ankle OA, or ankle pain and osteoarthritis, affects 12% of the population, and 4% of those patients have OA. And osteoarthritis of the ankle joint is primarily driven by trauma. So it would be, you may break your ankle, you may damage one of the ligaments around your ankle, and that predisposes you in 70% of cases to ankle osteoarthritis. And less common causes are things like inflammatory arthritis, crystal arthropathy, which is gout, infection in the joint, and something we call neuropathic arthropathy, which is arthropathic changes related to changes in the nerve around the joint. More common is rheumatoid arthritis. So the prevalence is 1% within the population. It affects women more commonly than men. And the incidence is peak in 40 to 60-year-olds. It's unknown etiology, but it's immune mediated, so it's your immune system attacking the joints. Even sort of 10, 15 years ago, we were seeing very, very significant hand and foot deformity, but we're starting to see less of that now that these are aggressively modified with drugs called disease-modifying anti-rheumatic drugs and biologic drugs, which suppress the immune system and the immune response within those joints. However, we do still see isolated. We can still see, even in patients who've got very well systemically controlled disease, we still see isolated inflammation in the foot and ankle. So you can have one joint that's still inflamed, even though the majority of the joints in your body are settled. And more commonly, we see it in the subtalar joint. And we have varying levels of deformity and changes within the foot. So it's a disease driven by something called synovitis, which is inflammation of the synovial lining of the joint. That joint becomes inflamed and swollen, and that leads to something called tenosynovitis, which is inflammation within the tendons itself. And this is an example here. This is a patient who's got, the ankle's very swollen, but you can see it follows a certain pathway down the foot here. There's a big tendon that comes down the side of the foot here, and also around the big toe here. And this is a cross-sectional ultrasound. So we're looking through the tendon. So this structure here is the tendon itself, but this is the inflammation around the tendon. So that's that would be fluid around the tendon called tenosynovitis. So inflammation of the joint, and generally with inflammation. And we can target those isolated joints very well with things like steroid therapy, where we inject the joint to suppress the inflammation, and the same with the tendons. In the foot and ankle, it's more common to see disease in the subtalar joint and the lesser toes. And what happens with it, and specifically in the forefoot, is we end up with erosions of the joint. So this inflammation causes almost like punched out mottling of the joint. So it essentially erodes the bone around the joint. So where the metatarsal meets the toe, we end up with these little punched out erosions around the joints. And it's more common at the fifth toe joint and the lesser toe to the second and third. Retraction of the toes is common. So this is a really good example here where the toes start to retract, caused by periods of inflammation. But we also get the fatty pad tends to move away from the area it should be protecting, and we end up with quite marked damage to these joints underneath, because if there's nothing there to protect the bone, it puts it more at risk of damage or pain. So, it's like walking around with no tissue underneath the bottom of your foot. Bursa formation. So I just have to move my screen so I can see what I'm talking about. Bursa formation is common. So you get these fluid-filled sacs across weight-bearing surfaces. And this is a good example across somebody who's got quite extensive big toe osteoarthritis. And nodule formations. So these are called rheumatoid nodules. And also callus formation over areas of high pressure, which more people may be familiar with. The seronegative arthropathies, so psoriatic arthritis or spondylosing arthropathies, more associated with where with more the spine or where tendons insert into bones. And one of the common presentations is something called dactylitis or sausage toe, where one of the toes swells up. And that's classed as a hallmark feature of the disease because the toe is essentially swollen. But when they look at that toe under imaging, you see lots of different types of involvement. So involvement of the tendons, the enthesis, so where the tendon inserts into bone, the joint itself and the soft tissue around it. This is something we typically see in the foot, which is the Achilles tendon is one of the biggest tendon, is the biggest tendon in the body. And this tendon becomes thickened and there's lots of bony changes of where the tendon inserts into the bone. So it becomes very thickened and very widened. So it's a hallmark feature of the disease again. And generally you get that on both ankles. And that's how you can differentiate it between just Achilles pathology. And this is an MRI image of somebody's Achilles tendon and their calcaneus, so the bone at the back of the heel. And we can see there's a very active disease process around this area here. You get involvement of the lesser toe joint. So rather than it being the big toe joint or the joints that attach to the toes, it's those joints within the toes themselves which are more affected, and the calcaneus that I've just alluded to, and less commonly at the ankle and midfoot itself. I'm just going to touch on these crystal arthropathies, so conditions such as gout, where you get uric acid formation within the joints. Again, a presentation in the foot and ankle and the midfoot, and it can be a very painful condition, which is generally first line managed with non-steroidal anti-inflammatory drugs, and then you may go on to a drug like allopurinol, which maintains the level of crystals with the circulating levels of crystals in the body, to prevent you having a relapse or a flare of the condition. But what we can also see is tophi formation, where you end up with erosions in the bone, but you also get you can get these deposits under the skin, which actually come to the skin and sometimes break. So we, as a profession, we're involved in the care of those patients too. We might remove the tophi or manage any wounds associated with the condition, or again, try and accommodate large collections where we may not necessarily be removed, but we try and offload any pressure over the top of those areas. Connective tissues disease, again, less common again. Scleroderma and lupus, they're associated with fibrosis of the skin, so thickening, it becomes tight. Inflammation within the muscles around those joints. Vasculitis, which is inflammation of the vessels that come into in the body. And something called calcinosis, so you get these calcium deposits under the skin, which again can ulcerate. More commonly in the hands than the toes, but something we still see. We have a colleague at Leeds who's very internationally recognised for her work in this area, and they really are affected. But something maybe more familiar with is something called Raynaud's phenomena, where you get it's a vasospastic disorder. So the vessels, if you go from say a hot room to a cold room, the vessels contract and they cause this almost blocking circulation into the toes. So we get this really cold, often quite painful change in colour in the toes. And again, we work in providing health advice around trying to stop those episodes, or provide you with things like certain types of material and foot orthoses to stop that increase or decrease in temperature when you go from a hot or cold environment. And the one thing which is really impactful is tissue atrophy or loss of tissue. So you lose the muscles around those joints as part of the disease process, but you also lose the fatty tissue. So you end up with a very bony foot that is exposed to very high forces that would be normally protected by those tissues under the foot and ankle. So what do all these conditions mean? I mean, this is very, like I say, it's very brief. I could talk to you for a long time about any one of these conditions, but essentially these conditions change the way in which the foot moves, how the joint moves, and how we walk. We compensate for those that joint damage or that pain, or even during periods of inflammation, how we walk. And what's really important when we have changes in joint geometry or alignment, we have loss of muscle mass, is that we put things in place to try and help us either stop that loss in muscle mass or counteract that once we've had these periods of inflammations. And these conditions have a really marked effect on quality of life, in that you know, foot pain has a significant impact on quality of life, and often it causes a big reduction. But also we know that even if you've had a big systemic flare in some of the inflammatory arthritis, once that's addressed by biological therapy, you could have one joint that's painful in your foot, and the effect on your quality of life can be as bad as it was back when you first were diagnosed with your disease. Some of the complications that we see with musculoskeletal disease are deformity of the nails, so thickening of the nails, especially with conditions like psoriatic arthritis. So they become curved or thickened. That's skin and soft tissue atrophy, so the skin becomes thinner or the tissues become thinner, and this becomes more prone to trauma, more prone to joint deformity and higher pressure, which puts you more at risk of things like ulceration of the foot and ankle. And I put high pressures at the bottom there. So high pressures are the pressure that you put through your foot is the pressure that you put through your foot. But if you have a very bony, big toe joint, you may put a lot higher pressure through that part of your foot than you would anywhere else. I'm just going to touch on some of the guidelines. So in rheumatoid arthritis and osteoarthritis, that the use of the management of the biomechanical joint pain and instability has become part of their recommendations, and also the provision of braces, joint supports and insoles should be considered as part of core treatment, and also use of suitable footwear and things like changing lifestyle, so increasing exercise and weight loss. But also health professionals should offer advice on appropriate footwear, including shock absorbency properties, which is part of the core management of lower limb osteoarthritis. So interventions, I'm just going to have a very quick sip of water before I move on to the next bit. Exercise is a real key feature of that. So maintaining muscle mass and function is really important. An example would be, we know that in inflammatory arthritis, when you've had a flare, so you've had a flare of your condition, you become deconditioned, you may not have used the muscle in the way it should have been. So it's important that once you've had those flares, is that you return to exercise and you do some targeted exercise around weakness. And this is just a couple of examples. This is a wobble board you can stand on 2 feet, and the variability when you stand on it can help maintain stability around the joints. But also, if you're doing that in combination with a therapist, such as a podiatrist, they can give you condition-specific exercises around how you can maintain the muscle and joint function. And that's a spiky ball, again, that you can use to improve the intrinsic strength of the muscles that sit in between your metatarsals. So it's really good for maintaining the muscle integrity of your foot. It can also have a compensatory effect on other structures. So it may have a knock-on effect to your knee and your hip if you have weakness in your foot and ankle. And I've just put on there that it's important to think about staging of exercise related to injury. So you don't go back to doing the same routine you did if you've had an injury, but also it's the same with flare. So you won't be able to do certain things when you have a flare, but you certainly are encouraged to go back to a form of that exercise and build back up to where you were before after. And general exercise ideas about things like returning to running. You know, if you've had a 2-week flare of your rheumatoid arthritis and you're a runner, you're not going to go straight back to what you were able to do before, and using things like Couch to 5K can be really helpful. I've just put some links on there to 2 examples of NHS provision exercise and condition-specific exercises, but these should be done in conjunction with speaking to a suitably qualified allied health professional. The role of foot orthoses can be used to redistribute pressures on things like ulcerated foot deformity, but also those where you have more prominent, say, bony deformity of your foot. They can be used to alter the biomechanics of your foot or restore the biomechanics of your foot. And I think this illustration is quite a nice one, that in standing, you know, we're changing the heel position here, but functionally it will change the way in which your foot works. And it's not necessarily about stopping movement, it's about changing movement, in that we want to stop maybe your foot rolling over as fast. And foot orthosis is very good at those. You know, clinically, we know that it's very good at doing those. Use of casted devices or functional foot orthoses or prefabricated devices. There's now evidence to suggest that prevents foot deformity, and prefabricated insoles that are off the shelf, but you know, we're notorious in podiatry for blue petering insoles, where we add bits to insoles. there's evidence now that they are as effective as a casted device where you have an impression taken of your foot. But also shock orthoses can be very good. And there's some, the type of materials can make a big impact. So carbon fiber insoles are going to give you a lot more stability, but maybe more painful if you have soft tissue problems. And the use of additional things like top cover materials, either to reduce that fluctuation in temperature, reduce pressure, or provide comfort. Over-the-counter foot orthoses are available over the counter, so you can go to Boots and buy something, or you can go to a local market and buy something. But bear in mind, if you're going for something like that and you're looking for something that gives you comfort, if you can squeeze it down with your fingers very easily, they're probably not going to do anything for your pain. There needs to be some sort of structure, that insole, and needs to be able to withstand the forces that go through your foot. An example being when you walk, 1.3 times your body weight goes through your heel. So if you can squish it down with your fingers, it's not going to resist your body weight. But well-structured, soft cushioning materials can really help. Sometimes the things you buy from a shop may not be suitable for a disease flare. They can sometimes make your foot hurt, and we often see patients turn up with a bag full of insoles. It's just using the right orthoses for the right condition. And if you do have a lot of foot deformity, it's probably better going to see somebody who can help you. So a podiatrist, or again, a suitably qualified allied health professional. We've just touched on prescribed foot orthoses, again, casted versus prefabricated devices, and using the appropriate types and tailored to the specific conditions. So again, if you've got rheumatoid arthritis, you may need something that's going to prevent foot deformity. But if you've got psoriatic arthritis, it might be something that's going to change the way that your Achilles tendon's loading during normal walking. Now, moving on to footwear, I think we're coming towards the end now. So this is I put this on. This is Chinese binding of the feet, where this was where you used to bind feet. And I suppose this is just to illustrate you can get anything into a shoe if you try hard enough. And probably poor footwear is associated with a lot of increased pain. So you can spend £200 on a pair of shoes, but it doesn't necessarily mean it's going to be the right thing for your feet. They need to be wide enough for your feet, and they also need to be deep enough. And the structure of that sole needs to be appropriate, that it's going to provide enough cushioning. If you think back to that comment I made before about the amount of force that goes through your foot when you hit the floor, it needs to be suitable enough that when you hit the floor, it's not going to squish down too quick, but it's also going to allow your foot to function in a way that it doesn't, go very flat very quickly. And if you don't have foot pain, you can generally advise wear what you want. But if you have foot pain, you need to kind of take these things into consideration. So good footwear characteristics are low heel height. So you don't wear really high-heeled shoes, because it will increase the pressure on your forefoot, but it also change the way in which you load your heel and your ankle. A moderate to firm heel contour. So essentially, the heel is stiff enough that it resists some of that movement. The shoe fastening is appropriate, so either laces or Velcro, so you can properly fasten your shoe, or you can, if you have any hand involvement, you can use Velcro to fasten up. Slip-on shoes tend to be more closer to your foot, so they will naturally press more on the top of your shoes and can associate with the formation of things like corns on the top of your toes or rubbing. And lacing style can be important. So if you've got midfoot osteoarthritis and you've got lots of bony lumps on the top of your foot, doing something as simple as changing the lacing technique, that you miss that bony bit and you go a hole above there and leave a gap, can be enough to decrease the pressure on the top of your foot and decrease your pain. So there are important considerations to take into account when you're looking at footwear. Prescription ortho footwear can be used. I've just used this trainer at the bottom here. Excuse the holes in it, but it was used for a research project I did where we looked at movement within shoes. But that is a good example of a trainer that you could wear around the house as a slipper. And quite often in rheumatology, somebody comes to me and they've got footwear and they're walking around with a very thin slipper. The first line treatment we do is say, go home, buy yourself a cheap pair of running trainers. You might not like the idea of wearing them out and about, but try them in the house as slippers. And 90% of patients will come back and say they've had a significant improvement in their foot pain just by doing that one thing. And they cost, those trainers cost £30. They're relatively cheap. But as we go through the levels of foot deformity, the requirements for our footwear changes. So if you've got a fairly normal foot type, trainers and good fastening shoes are probably appropriate. But as we go up towards quite significant foot deformity, we're starting to look at ways we can try and offload these areas of high pressure, but also accommodate the deformity. And that may be that you need a referral to an orthotist who can make you a shoe. And these don't always have to be specifically bespoke, but they can be stock shoes where they're made in certain shapes which are appropriate for your shoes. So again, we know that we can improve functional capacity and reduce loading in combination with insoles, but traditionally prescription shoes had high levels of dissatisfaction and poor compliance, but it's changed significantly over the past 10 years. So what you might have thought was a really clumpy, ugly clown shoe, now you can get some really bespoke looking shoes that you wouldn't know it was unless you really, really looked. Self-care is really important. Sedentary lifestyle is associated with decline in all the things we've talked about before about loss of muscle mass. So if you're sedentary, you're going to lose that muscle mass and have increased pain. But when you in between those periods of flare or when you don't have a flare, it's really important to keep moving. Self-care of your nails is important. So you can file these thicker nails with a file. And you can also, unless you have a high risk of footwear at risk of infection, cut them, keep your nails at a relatively good level. We've already talked about house slippers, trainers around the house, moisturize your feet because it reduces the risk of you ulcerating or splitting your skin, and use pain management as part of your daily activities. So if you know you're going to do something where it's going to increase your pain, think about things like the use of paracetamol or whatever you normally take for pain to take before and during activities so you don't have these big peaks in pain when you're doing it. And monitor, it's really important to monitor your feet because if you're on something like a biologic or a DMARD, it does increase the risk of you ulcerating. So making sure that you monitor your feet on a daily basis, check for any cuts in the skin and just dry dress them with a normal plaster. So when to see a podiatrist? Well, annually for diabetic foot assessment if you have diabetes, any mechanical or inflammatory pain that you're worried about or there needs some differentiate between the two. And corn and callus. So looking to see whether these are mechanical in nature, which they generally are. This can be resolved with something simple as a footwear change. If you have foot deformity, we can help with that in regards to footwear advice, managing foot deformity, preventing foot deformity. You can access a podiatrist through self-referral in most trusts, so you don't need to go to your GP to be referred. If you search for your local health authority with the word podiatry, generally you'll find access through that. But you can also access through there's access advice through the Royal College of Podiatry, which I've provided a link for at the end of the presentation. But also the HCPC ensures that there's a certain standard of care that you're going to be seeing. And those who do not comply with that are essentially struck off and don't operate within the parameters of their professional practice. It's a protected title podiatrist. So you know you're seeing what you should be seeing. And there's lots and lots of self-care available. I'm just briefly going to touch on this because I know I'm slightly over, but there's a lot of research going on in foot and ankle disease. There's an international foot and ankle consortium which has set these research priorities around the diagnosis, epidemiology, burden, outcome assessment and treatment of foot and ankle osteoarthritis. And the James Lund Alliance has a foot and ankle specific 10 top priorities in research for health as people, clinical academics and academics like myself are trying to improve the care of foot and ankle disease, and my specific interest is in ankle osteoarthritis. And there's just some resources there at the end, so I think they'll be available. So these are really good free resources where you can read about common foot problems, how to do self-care, how to access care, and charitable organisations, which, as you're aware, charities like Action Arthritis provide an awful lot of information and support for people with arthritis. Thank you very much.
Thanks, Richard. It's so interesting to hear you talk about that and the small ways that you can sort of make little changes in your life, but actually have a big change in your feet.
Yeah. So it's it's something as simple as changing your footwear can make a really big difference. But there's certainly, as a profession, we see a lot of these very common foot and ankle pathologies, which are not always picked up in clinical practice. But also it may be as simple as if you change your shoe, that the corn that you've had on the top of your toe will go. You take the pressure off, it will go. You have some foot orthoses because you have midfoot pain, it may not go, but we can certainly make your quality of life better or improve your outcomes.
I'm sure David has some questions for you, but just before then, I'm seeing a few questions about if people can get the slides for this in the presentation. And yes, we will be sending those after the webinar. We'll send them to you in an email, and you'll also be able to watch this webinar again. We'll send you a link to that afterwards. But David, I'm sure you have some questions.
Yeah, there may just be a couple of the images I can't supply because they're copyrighted as part of the institution I work for, but I'll certainly leave in what I can. Yeah.
Thank you, Richard. That was a really interesting, informative presentation, and I appreciate you trying to condense quite a lot of information into that spell. But I learned loads there myself. I loved the tip, which was really useful, which I'll certainly relay to my patients, where if you're choosing an orthotic insert, that pinch test, that's really useful, because I mean, if you send someone off and say, well, I think you need to, get some kind of insert support, just knowing that helps. And I think the one of the more common questions we've already had leading up to this was, what to wear around the house if you do have any kind of problem. I think, just the simple fix of wearing a pair of trainers for that kind of that first tier of issues is really useful. And I think actually this isn't one that I planned to ask, but leading on from that insight, where do you sit on just like keeping good foot health in terms of the musculature of the small intrinsic muscles of the foot strong and functional? Where do you as an individual sit with a lot of people do, obviously in the summer months, where they kind of walk around in barefoot or flip-flops, or even some people who exercise quite regularly believe in wearing the minimal footwear, which you're probably aware of, which looks like a trainer, but they've got the toes, etc. in them. Do you have any particular opinion on those?
Yeah, I mean, it's quite, I think it's, I think it comes down to that thing. If you don't have any foot pain, wear what you want. It's, we're not, if you don't have foot pain, you wear what you want. I wear what I want when I'm at home. I wear flip-flops in the summer. If my feet hurt, I put my trainers back on.
Yeah.
But essentially, I think flip-flops, a good example is people generally get more pain in their feet when they're wearing flip-flops, is because you have to claw your toes very hard to maintain your foot in the flip-flop. So if you've got weak intrinsic muscles, it's going to make your feet cramp. It's going to make them feel sore. Minimal shoes. Again, it comes down to injury and pathology. I think there's been some research done about footwear in sports. Is that if it feels comfortable, it feels comfortable. But if you've got foot pain, we're in a different realm. Then if you've got arthritis and you've got a problem with your arthritis, we're in a different realm. So probably minimally invasive, minimally material shoe is probably not that great for you, because it probably doesn't give you the support or the protection that your feet may need. And I think there's availability there. I think the one I showed there is from a company called Heel Fix. So they have a spiky ball where you can, they have videos where you can do these exercises with the spiky ball to improve the intrinsic muscles in between the metatarsals and your big toe, and that clawing action, which is so important in walking.
Yeah, I think that's they're nice and simple. I think I was reasonably familiar with those. Not the spiky ball though, so that's really good to know. If someone hasn't got access to a spiky ball, can they use anything else, Richard, like a
towel,
tea towel or something?
Tea towel.
Yeah.
So the most important thing is being able to, is something you can physically grab. So if you get a folded over towel, sorry, there's a piece of machinery just started working behind me.
Oh, brilliant. Yeah, carry on, mate.
Yeah, typical. If you fold up a towel, several layers, in the first instance, and you try and pick up that towel, you'll feel it work. You'll feel the muscles between your toes working. If that becomes too easy, you can unfold a layer, and it becomes harder for you to pick up that towel. So we always talk about doing things to fatigue. So if you try and pick it up with your toes, you try and lift it off the floor. You do that until you start the muscles between your toes start to feel tired, in your foot feel tired. Have a rest, repeat. Have a rest, repeat. So you do things to fatigue, and if that's too difficult, you just reduce down you just reduce down that level until you're getting some sort of feeling of the muscles are working. Does that make sense?
That's really interesting. Yeah, it does make sense. I guess what would be useful to know in that regard for that sort of protocol is how often someone should do that, because I know we'd probably be asked that.
Yeah, I don't think there's any standardized exercise prescription for patients in regards to what's the best way of doing things. Right. And certainly, this is probably where, if you have rheumatic disease, it's probably better to go and see someone because they'll give you something specific to you.
Yeah.
But generally, we work on the principle of fatigue and stop. So you start to fatigue, you have a rest. You could do a certain number of reps, but if you can't do 10 reps, you can't do 10 reps. But if you can do it till you fatigue, you can do it till you fatigue. So for instance, one of the big tendons that comes down the inside of your ankle, inserts into the bottom of your foot, is really important for tipping your heels during gait. It's quite often, it's the tibialis posterior muscle comes down and inserts into your foot. And we generally give out heel raisers for those. And if somebody's very deconditioned or they've got quite advanced disease and their heels still tilt because they've not been that affected yet, it may be that we do a 1-inch raise off of the floor. You just go 1 inch off the floor, enough to make those heels tilt. And you might ask somebody to do those until they start to feel tired and have a rest. But what you'd be looking for is progression over a period of time. Yeah. So you might not go any higher, but you might be able to do more of them. As that progresses, you may be able to lift your heels higher off the floor, but that might become harder again. So it's about progression.
That's fascinating. Thank you. That's really useful as well to have your thoughts on that. I know we spoke briefly before, Richard, about some of the crossovers in terms of your practice and what you do, and as a podiatrist, how you view exercise. And certainly a big part of what we do at Arthritis Action is to try and encourage movement, activity and exercise to stay as strong as we can with those muscles around joints, even if they are affected with arthritis. And obviously, when we think about biomechanics, I think often it's something that's not given enough attention, i.e. the foot, because obviously as human beings, we engage with the world via our hands and our feet. And in terms of the muscle chain that we often speak about, in terms of the movement, like for instance, standing up from a seated position, obviously the starting point for that is actually your feet. And what advice can you give, or can you give any insights into how you would approach trying to keep someone strong in that movement whilst they are experiencing, difficulty with a pain somewhere in their foot or ankle? Is there anything that could you give us an example of how you would approach that?
Yeah, so we'd approach it in that we would try and, I think the example we talked about before I came on is that if the muscle's too long in a position, and this comes down to the position of your foot, it's something that is, your muscle's meant to, we talk about something called eccentric contraction of a muscle and concentric contraction, which is, eccentric is when the muscle gets longer, and concentric when it shortens up to do the power part. And the example I always give is, when I'm talking to patients, I'll just show you, I'll put this out to show you just for people's thing is, if I try and pick up this bottle and it's full of water, if my arm's in this position and I pick it up, it's easy. If my arm's is straight and the muscle's as long as it can be, it's harder. It's much, much harder because I've got to really work to pull that weight up. What insoles we try and do sometimes with foot orthoses is we try and put that muscle in the foot, or even with footwear, is we try and put that length of that muscle back to its optimal working position, so that when it's working during its normal activity, it's not having to work really hard to do its normal movement, because if it's really weak, it won't do it. If it's too long, it won't do it, or it doesn't do it in the same way it does. So a lot of it's trying to restore the function of the function of that specific structure. So the muscle that comes down the side and it's inserted at the bottom of your foot is a really good example of that. If your foot's really, really flat, the muscle's too long. So if we put you in a better footwear, or we do something with insole which restores the functional position of that muscle, it's going to help rehabilitate that muscle and restore its function.
That's fascinating. Yeah, it's really useful to hear that, because often, foot pain, ankle pain can be a real showstopper for someone who is previously fit and active and, wanting to maintain some strength of the lower limb more generally. And I think knowing again that a podiatrist can help with keeping us moving, and in terms of unloading certain joints and still keeping the intrinsic strength of the muscle is fascinating to me. That's a real kind of a useful thing to know about. I think moving on to, I guess, more general questions then, Richard. One of the things that we've been asked a lot in terms of how to engage with a health professional. So obviously, given like, potential waiting lists, etc., and people who want to come and see a podiatrist, are there any bits of information that would be helpful to save time in that consultation, so you can get to the prescription and the understanding of how you're going to help that patient? So, for instance, what could generally that member of the public, that patient, bring along with them that can save time and make life easier for you all in terms of just being more efficient in that consultation?
So I think generally it's not the consultation which is probably the problem, but we'll talk about some. It's not. I suppose it's not the consultation that's generally the issue. It's getting to the consultation, because there's a lot of strain on the NHS at the moment. In that COVID's sort of obliterated. Well, I wouldn't say obliterated, but essentially made it a lot more difficult to access these services. There are, I'm talking to you as an NHS podiatrist, but there's also access to private podiatrists who are Royal College of Podiatry registered, and they adhere to the same professional standards as I do in the NHS. But I think, going back to the original question, so if you can't access your NHS services, there are private practitioners who you can access, but obviously there's a financial implication to that. If you go to a consultation, the things that are always really helpful is bring your footwear, bring your orthoses that you've been prescribed before, if you've been prescribed them before, or bring us the ones that you bought with you, bring a pair of shorts, and bring a list of your medication. And straight off, we've got everything, which sounds like a lot, but actually, if you brought that, I'd go look through your bag and say, right, you've had that, you've had that, you've had that. The list of medications gives us some indications of the other medical conditions you can have, because, as we're all getting older, we now have patients who have multi-morbidities. So it may be you have osteoarthritis of your foot, but you may have diabetes. You may have, maybe come to me with a musculoskeletal complaint, but you may have diabetes. You may have vascular disease. You could have lots of other different conditions. And I suppose it comes down to how healthcare professionals have changed over time. Is we're not just foot specific anymore, as you are in your own profession, David. That we work alongside lots of different clinicians. We have lots of training now in lots of different multi-morbidities. And if you come and you have your vascular assessment checked, and we see that you have an arrhythmia, we listen that your heartbeat's not quite right, we would refer you back to your GP to have that investigated. It's just these things. It's like, but if you're on medication for that, we probably know that it's being addressed already. If you have diabetes and you come with your medications, we know it gives some indication of how severe diabetes is. If you've had a recent blood test for your diabetes, something called a HbA1c, if you come with that information, we know how well controlled your diabetes is. If you're on, if you have rheumatoid arthritis and you recently had a depomedrone injection into your bottom, it gives an indication that that may be related to a disease flare. So we may not see inflammation when you present at that time, but it may be that actually you're in between treatments. So it gives us lots and lots of information that you may not think is relevant to the consultation, but it may help us guide either how we treat you or how we think who you need to access as part of your clinical management of your health in general.
Yeah, that's great. It's really informative. There's quite a few parallels there to what ideally people bring along to either an osteopathy or physiotherapy consultation as well. So it's very much in keeping with bring that along, and it saves a lot of time in the front end of that. On that, are there any tips you can give to some of the osteopaths and physiotherapists watching this webinar? Because there will be some who watch it now, and then obviously some who watch it later, in terms of when to refer to your profession, because often we get people who come along with knee and ankle or foot pain, obviously in clinics, and knowing when to refer to you guys is actually, you can just give us I'm really aware of the time, to give us a shortened version of that answer, Richard. And then
a really short version of the answer is if you have an inflammatory arthritis, if you are if you've got rheumatoid arthritis, psoriatic arthritis, spondylosis arthropathy, if you have a musculoskeletal complaint, it forms part of your musculoskeletal standard of care, and they should have a foot assessment really if they're being managed from that perspective. If it's a single joint arthritis and they're not necessarily being treated for anything, so it might be a problem with the big toe joint. If you think that your intervention, your physical intervention, isn't having the results you think they're having, then it may be biomechanical issue, which we probably have the expertise in, specifically the foot and ankle. And what was the other question you asked me? Physical exercise, when to refer to us.
Yeah, when to refer, really. Yeah.
And if you've got somebody who's got inflammatory arthritis, and you're not sure whether it's a flare or whether it's a mechanical cause, refer.
Yeah.
Refer. If you think a patient has a condition that would benefit from some sort of mechanical intervention for a period of time. So, we've moved away from that thing where if you have foot pain, you don't need to wear insoles for the rest of your life. You may need to wear it for a 6-week period of rehabilitation. Send them through, refer them through. And then anything soft tissue related that isn't responding very well to exercise or what the other treatment that you provide, refer through. Vascular issues, anything like that, lower limb related.
Amazing. That's great, Richard. Oh, and I'm going to hand over to you for any other questions that have come through.
Absolutely, yeah. Thank you to everyone who's asking questions. Sorry if we can't get to all of them, but we will try to answer your questions afterwards by email if we can. Unfortunately, as I said, we sadly can't answer any personal questions regarding your specific medical circumstances, but we'll try to answer more general questions that we get here about podiatry. Richard, we've had a few questions from people saying, would you recommend any specific brands of orthoses or shoes, or are there any sort of not to go for as well? Some people are asking, what do you think about Crocs, which are very annoying?
I haven't got a pair myself, but it comes down to essentially, I don't think I really can in this environment say which brands I would recommend. I think it's more about the properties. So it's about the fact that you want something like a running trainer or a walking trainer that is thick, is not very soft, and doesn't bend and doesn't twist very easily. So you want something that's got a fairly firm sole and thick. So Asics do a really good one. Hoka do a good trainer. The soft Skechers aren't that great, but the firm ones are. There's brands of those that come through are really good. You can go to a regular high street retailer. I'm not going to mention the name, but the ones that sell lots and lots of things, you can pick up something there for 30. Those trainers I bought there were from like one of those retailers where, that was an Asics trainer. It's relatively cheap in regards to footwear, but if you were buying them to wear at home as slippers, they're a really good investment. But if it's running related, again, it's different again. So there's lots of different things related to the type of condition you want. But if you work on the general rule of they should be thick soled, they should have a slight curve at the front for your big toe. If you bend them at the front, they should just bend a little bit where your big toe joint is, but you shouldn't be able to twist them and you shouldn't be able to bend them in half because they won't give you essentially what you need. Fastenings, again, always go for a fastening. So either a lace or a Velcro fastening, and make sure it's got a well-structured upper. So if they're really flimsy on the top, the material part of the shoe, they're probably not going to be as good as something that's a little bit more structured, similar to the picture that I showed you before of that white trainer.
Really useful, thank you very much. We might just have time for one.
Oh, sorry, the Crocs thing.
Oh, yes.
Crocs are thick. They have a formed arch. They're not necessarily appropriate for everyone because they've actually got quite a raised arch in it profile. You can't put orthotics in them, but it doesn't necessarily mean they're not suitable for some people. So if you wear them and your feet don't hurt and you don't need an insole, then great. It's something between you and the floor. And they also tend to have a band at the back that you can put over. But just be wary that, again, if you've got any soft tissue problems, that your foot will slide back and forward in the shoe because it doesn't have a physical fastening.
It's really good to know. Yeah, it's a good general rule, really, I guess. Yeah, that if it doesn't hurt, then you're doing okay, I think. Very quickly, we have time for one more. People are asking about bunions. Are bunions arthritis related? And what treatment would you recommend? And when are they serious enough for surgery?
So bunions are the most common osteoarthritis that you get. It's not a wear and tear thing. It's related to incidents of trauma. So the two bones knocking together, or some damage to the capsule, or some pinching of the tissue. It's an inflammatory process. So at that image I showed you before of the red dots within the joint itself is inflammation. So again, moving away from that wear and tear thought. It's one of the most common osteoarthritis. You tend to have either a lump at the side of your toe, or you end up with bony deformity on the top of your toe, and it can also drift out, so your big toe can start to drift into your foot. It comes down to pain and function and quality of life as to when you should consider a bunionectomy or a chylectomy, which is the one where they shave the bone off the top of your foot. And it comes down to pain. So pain's a good indicator of when you should essentially consider surgery. If you just don't like the look of it, it doesn't necessarily mean that you need surgery. It's related to pain and function. So if you do something where the big toe function is very important in your activity, then it probably needs to have that sooner rather than later. But that's a conversation to have with an orthopedic or a foot and ankle surgeon. But we certainly, from my perspective clinically, it's the last thing that you would do is to have an invasive procedure of your big toe joint, or it removed. You can do a lot with footwear. Addressing the biomechanical issues are often the first line of treatment, or changing your footwear. Again, same properties. Stiffer soled shoe at the front means your big toe joint doesn't have to bend as much or work so hard. And again, that can settle down a lot of your problems straight away.
A really informative answer. Thank you very much. I think we're just out of time now, so thank you both, really. This concludes our webinar now on arthritis and podiatry. Thank you, everyone, for joining us. If you'd like any more information on the subject or anything else in relation to your arthritis, you can visit our website, which is www.arthritisaction.org.uk. If you go there, you'll see that we have a number of useful resources that can help you self-manage your condition. This includes detailed information on things like exercises, dietary information, well-being resources, and tips on staying connected. We've also just launched a new Arthritis Action podcast as well, which covers a wide range of topics to help people living well with arthritis. These are available on our website as well. I should also say a video of this webinar will be made available shortly on our YouTube channel if you want to watch it again. So if you're watching this live, we'll send you an email with a link to the recording once it's available. All that's left for me to say then is to say thank you, Dr. Richard, and for David for answering our questions today, and to thank you, all of you, for joining us. We hope you all stay very safe and healthy, and we look forward to hearing from you soon. Thanks, everyone.
Thank you.
Thank you. Thanks very much, Richard.